Thank you also for this excellent topic. That was the opportunity for me to go back in the university, in the library, and to find a lot of things, and to realize that we are too often obsessed by the quality of the results of our surgery, and not to find, in fact, to the basic of physiology and the quality of vision. And in fact, it's absolutely essential, because when we treat with the vision, we have to go back to the functional. First thing, we remember that in monocular vision, we have the central vision that allows the precise vision with the high spatial frequencies and resolution. Peripheral vision with the low frequencies allows us to detect the peripheral movements and to get the archaic alert mechanism. It also allowed to have a precise analysis of the target with its position, its moving, and its speed in the field of view we get. The monofocal vision includes a lot of things. The things of color with the three kinds of cones that can discriminate the red, green, and blue. To see also the contrast, but to get the localization of things and the movement. In binocular vision, the both eyes work together. The field of view is wider. It's almost 180 for just 150 for one eye. The binocular summation gives us the ability to detect fade objects with more acuity. Stereopsis, in which parallax provided by the two eyes, different position on the head, give precise depth perception. And the singleness of vision, that is the best thing, or binocular vision, in which this single image is seen despite each eye has its own image in the field of the panum fusional area. The two eyes interact to influence each other in three ways. First one is pupillary diameter. The pupil gets wider in dark from 5 to 9, depends the age of the patient, and become narrower in the light. And this size will decrease with the age. The light falling in one eye affects the diameters of both pupils, with the ipsilateral reflex and the contralateral consensual reflex. Accommodation and versions are absolutely essential also. If one eye is open and the other closed, and one focuses on something close, the accommodation of the closed eye will become as that of the open eye. Moreover, the closed eye will tend to converge to the point of the object. The accommodation and convergence are linked by a reflex of accommodation and convergence that we must respect and use during our refractive surgery. The first point is the interocular transfers. The state of adaptation of one eye can have a small effect on the state of light adaptation of the other. The after effects induced through one eye can be measured through the other. For binocular vision, to maintain stereopsis and singleness of vision, the eyes need to be pointed accurately, which is controlled by the 6 extraocular muscles. The disorders of binocular vision can income with slight differences in the length or insertion position or strength of the same muscle in the two eyes, that can lead a tendency for one eye to drift to a different position in its orbit from the other, especially when one is tied. The refractive surgery can create significant consequences on oculomotor balance by changing one or several mechanisms: the change in visual acuity of each eye, the change in image quality, the change in the eye having the best acuity. The oculomotor system is particularly faint in case of anisometropia, amblyopia, and strabismus. So the preoperative consultation must include a precise screening and clinical examination with medical history, visual inspection, precise with visual acuity, spectacles worn, the refraction before surgery and to which the patient is used, the binocular vision with oculomotor balance, stereopsis, and essentially eye dominance. For medical history, we have to look at anything that can disturb or modify the precision of the refractive surgery. Medical diseases, especially thyroid pathology or neurological, traumatism, sprain, fracture or whiplash, surgical history indeed of ophthalmology or orthopedics. The consequences also of anesthesia, which general or local, and indeed the medical treatments that can interfere on accommodation, anxiolytics, hypnotics, morphinics, and so on. And indeed for the food orthosis for the global quality of equilibrium. For visual inspection, it must be very precise. The refraction with monocular test should use a chart with logarithmic progression. The links between the sensory motor and the refraction are very close through the accommodation relation, convergence relation, and must be respected. Any accommodation effort to distance vision to an undercorrected hyperopia or overcorrected myopia before surgery with the precedent glasses of patient can generate permanent disorder in the ocular system. So it's necessary to get subjective and objective refraction, and we have to use cycloplasia till the age of 50 with a human guy. Biocular, not binocular test with the polarized glasses allows to get a good balance of the visual accommodation and the good balance of the sensorial feeling, which can be different from the preoperative refraction. The binocular tests must show the best visual acuity, the best near visual acuity, and to research aphoria. The orthopsia screening has to get precise analysis of eye movements, screening of voluntary motility, duction and version, the different versions in ESO or exotropia, pursuit and saccades, and the power of convergence near. The disorder of binocular vision are analysis with the cover or uncover test, esophoria for latent deviation, exophoria or rarely hypophoria or extremely rare the cyclophoria. We can have the tropia, which is more theoretically evident, but in fact we can have microtropia or even hyper or hypotropia that can perturb the quality of the postoperative results. The stereopsis measurement is the appreciation of the depth perception. It needs isoacuity, perfect parallelism of the visual axis, and a normal vision development. We have to use random dot tests under 80 seconds of CAP to get a good analysis. The absence of a good stereopsis is an index should alert us for the danger of the possibility of disconvenience after surgery. This refractive surgery can induce side effects. The anisometropia, the statistics reveal that usually ametropia are symmetric on both eyes, which allow the same work in accommodation and conversion. Any break in this symmetry can disturb binocular vision and the comfort of the patient. Aniseiconia is very difficult to analyze. The correction, but we know that the correction of axial anisometropia with glasses allows to get same retinal image size on both eyes, which is completely different with corneal or intraocular treatment that increases the anisocoemia. These different retinal images on both eyes can be very disturbing for the patient, with discomfort which is sometimes difficult for the patient to precise, but really uncomfortable, or even diplopia or image confusion. Also, the dominance of the eye has absolutely to be well precise, because inverse, the eye dominance can also be very disturbing for the patient. So, in conclusion, refractive surgery may influence oculomotor balance and binocular vision. The ocular function screening is necessary before any surgery, with objective and subjective refraction, analysis of oculomotor balance, and stereopsis. The test must research abnormal dominance and the anisometropia, not to get unsatisfied patient with, by the way, very well done and realized surgery. Thank you.